Okay, so basically there is a question: how does a case of maxillary carcinoma present to you clinically? How do you investigate such case and enumerate the treatment options for maxillary carcinoma? So these are the questions that has been asked from the tumor of the paranasal sinus, and today's topic is tumor of the paranasal sinus. Okay, or it is also known as the sinonasal tumor. The most important one being the inverted papilloma, very often asked question, because blood-stained nasal discharge, unilateral pink friable mass which is arising from the middle meatus area in an age group of 55 years. Classically these are the history that has been often asked in the case of inverted papilloma. Talking about ossifying fibroma, simple papilloma, and osteoma. Osteoma and ossifying fibroma are usually asked. What is osteoma? Osteoma is a mass that is seen in your frontal sinus. Okay, I'll talk about that later, much more detail. Ossifying fibroma means, remember, ossifying. Ossifying, the word means there is something is ossifying, something is changing, something is converting. So normal bone will actually convert into a fibrous bone, and that will lead to a ground glass appearance, which we will be learning certainly. The most important malignant tumor of the paranasal sinus is squamous cell carcinoma and adenocarcinoma. Anaplastic transitional malignant melanoma, salivary gland tumors, and rhabdomyosarcoma are also there. There is a salivary gland tumor part 1 video. I'll be posting soon on different other parts also, certainly. Now let's talk about osteomas. So before going to the slides proper, I would like just to give you a brief account that what is osteoma. Osteoma is usually seen in your frontal sinuses, and they are actually an incidental finding. The only problem created by osteoma is sometimes it may lead to recurrent sinusitis, because of which there will be a problem. Recurrent frontal sinusitis will present you with a they will present you with the excellent they will present you with the office type of headache. Okay, office type of headache. Osteoma are commonly incidental findings in frontal sinus X-ray. Okay, so usually if they are not creating any problem, just leave as it is. You don't need to do anything. Okay, majority are asymptomatic and do not grow. Surgery is done only in the symptomatic osteomas, and those they rapidly grow in size. Okay, completely removal of the tumor with this base attachment, it is done by bicoronal osteoplastic flap technique. What does that mean? That means you are going to cut from here and here, there are two incision, and then you are going to remove the with the help of neurologist as well as ENT expert and the surgeon anesthesiologist. Is the multi-sectorial approach for removal of osteomas. Okay, talking about ossifying fibroma, see here, frontal sinus osteoma. Can you see that the haziness pattern over here in the frontal sinus? Yes, you can. The bicornal osteoplastic repair, I told you that there are two lines of incision over here like this, and then you remove the osteomas. Tumor exposed, just remember bicornal osteoplastic flap repair. If you just remember this word, bicornal osteoplastic flap, that will be more than enough. Okay. Next is ossifying fibroma. So what is ossifying fibroma? Ossifying fibroma, it is usually seen here in the maxillary sinus, and what happens is basically one pattern of bone is converted into, it is ossified into the fibrous pattern. The medullary pattern, the normal medullary bone will be converted into a fibrous pattern, and what will happen because of that, it will look a ground glass appearance on CT scan. Okay, and you need to remember that you are going to remove this mass. You are going to remove this mass, and much more details we'll be talking in the slide. So it is also known as fibrous dysplasia. Dysplasia is changing, isn't it? So normal medullary bone is replaced by abnormal proliferation of the fibrous tissue. So abnormal proliferation of the fibrous tissue, normal medullary bone. If you have a you have a normal bone, and that normal bone is now being converted into a fibrous tissue, resulting in distortion and expansion of the bone. Now you will see in the next slide that how expanded this cheek will be in a woman. Okay, in an African woman in this slide. Ground glass appearance with reasons of osteolysis and calcification. So why ground glass appearance? It will have areas of calcification. Complete surgical removal is the, see here, as I told you. See, this woman has an ossifying fibroma, which is basically a normal medullary bone will be converted into fibrous tissue, and that will create a mass over here, and this mass will be completely removed. On CT scan, you will see ground glass appearance, as well as you will see areas of osteolysis and calcification. Can you see this area? Full of calcium deposit, osteolysis area. See here, regions of osteolysis, ossifying fibroma. Now let's come to inverted papilloma. Very, very important topic. Listen to me very carefully. This is also known as Snickdarian papilloma or Ringer's papilloma. What happens is a 55-year-old male comes to the Department of ENT with unilateral bleeding. Okay, if it comes with a unilateral bleeding, you can also think of other differentials. What will be the other differentials? Number one will be a foreign body. But for foreign body, there should also be a unilateral foul-smelling nasal discharge. Is there any nasal discharge in this condition? Okay, there might be nasal discharge because of recurrent sinusitis caused by the papilloma, but there will not be foul smelling discharge. There might not be foul smelling discharge until and unless the patient is of atrophic rhinitis. Okay, atrophic rhinitis will come with a merciful anosmia, of course. Now, but whenever we talk about inverted papilloma patient, they will come with a unilateral nasal bleed, and they will come with a pale pink friable mass. Now remember, pale pink type of friable mass, pinkish type of mass in the nasopharynx if it is towards the nasopharynx, and if it is a juvenile age group, what you will think of? You will think of juvenile nasopharyngeal angiofibroma. Is the location towards the nasopharynx? No, it is not towards the nasopharynx. Is the age group of juvenile age group? No, it is not a juvenile age group. It is a age group of your this one. Adult age group, 50 years old age group, right? So that is why whenever we talk about this one, so see, inverted papilloma, also known as Ringer's or Snickdarian papilloma. Okay, it's a locally aggressive tumor and highly recurrent. After you go for excision, there might also be again recurrent. Okay, sinonasal tumor, locally aggressive sinonasal tumor, common in male between 50 to 70 years. Look at the age presentation. Arises from the lateral wall of the nose. Okay, unilateral pale pink friable mass. Okay, unilateral friable pale pink mass arises from the middle meatus, exactly from the lateral wall of the nose, from the middle meatus. Diagnosis made by punch biopsy. Can you see me why inverted papilloma is even known as inverted? Because the normal epithelial growth, so if this is your epithelium, this epithelial growth grows away from the stroma like this, right? And there comes the stroma. But in the case of inverted papilloma, what happens is, in the case of inverted papilloma, these epithelial projections, they go inside towards the stroma like this. See here, inside towards the stroma, and this is the area of stromas. That is why this is known as an inverted papilloma. Inverted papilloma, the treatment is medial maxillectomy with en-bloc ethmoidectomy. Okay, medial maxillectomy and en-bloc ethmoidectomy by lateral rhinotomy or mid-facial deglobing. Mid-facial deglobing means the same. Mid-facial degloving means you are opening like a globe, and lateral ferrugation means you are giving incision from here like this and like this. Okay, lateral ferrugation. Now it will come. Inverted papilloma have marked tendency to recur after surgical removal. I recently wrote here. Squamous cell carcinoma is present in 10 to 15% of the cases, and radiotherapy is avoided. Not well differentiated, but can you see this? Mustache? It is whitish in color. Old male. Even if you can't make out, suppose there's a history and there's this picture. If you come, there's of course a mass arising from this area, no, lateral wall. There's a mass. Okay, but not that well appreciated. This diagram is not that well appreciated, but I can see this mustache and I can say that this is an old person. So, contrast of CT scan PNS, left intranasal mass with opacification of the ethmoid and the maxillary sinus. See here, all covered, no? That is why medial maxillectomy with en-bloc ethmoidectomy. Okay, bone destruction can be seen, and bony destruction, if there is any bony destruction, the investigation of choice will be CT scan. For bone appreciation, we go for a CT scan. For cartilage, joint, tendon, ligaments, we go for an MRI. Okay, so bone destruction, CT scan, and medial maxillectomy with en-bloc ethmoidectomy. Punch biopsy. Can you see this epithelial? It has over here like this, and then it has gone inside. This is why this is known as inverted papilloma. Treatment: medial maxillectomy with en-bloc ethmoidectomy and wide excision of the mass by two incision. One is lateral ferrugation incision, other one is mid-facial deglobing. Can you see the lateral ferrugation incision? As I told you, Mark it down like this. Lateral Ferguson, lateral rhinotomy incision. Osteotomy cuts. You can see that there's osteotomy cuts can be done. Tumor is being removed. See, stitches are there now. Midfacial degloving. Yes, you're opening a face like a globe. You're opening a face like a globe. Okay, this was osteoplastic repair. Okay, this one bicoronal osteoplastic repair, and this is midfacial degloving. You're opening with the face. Okay, midfacial degloving. Now let's come to the sinonasal malignancy proper. So let's discuss from here only. So sinonasal malignancy, whenever we talk about the sinonasal malignancy, what we need to understand is, of course, we'll be talking about most commonly it is squamous cell carcinoma. Okay. Remember, they are more common to someone who work in the wood dust. Okay. Of course, looking at the other malignancies of the body, sinonasal malignancies has less incidence, but still someone is presenting with this area with maxillary sinus. What are the presentation? Remember, if you know the location of the sinus, it will be very easy for you to understand. So above the sinus, above the most common affected is the maxillary sinus. Above the sinus, what do you have? What is this? This is your eyes. Medial to the sinus, what do you have? You have your nose, right? Near the sinus at the lateral aspect, what do you have? This is your cheek. Okay, this is your cheek. And of course, if you go posteriorly towards your, what do you have? You have your pterygoid muscle. Okay, this is a maxillary sinus. Downward towards your cheek, then here there is your pterygoid muscle, movement of the jaw, right? And then above here, if it goes to the brain, this is your intracranial extension. So we will be learning in this pattern. So understand that maxillary sinus is the most common amongst all, and 80 to 85% is squamous cell carcinoma, and male is much more affected, and it is seen in 45 to 60 years of age group. Okay, and can you tell me maxillary sinus, like if someone presents with the maxillary carcinoma, what are the other things that you should think into your mind? What should be other things that should insert into your mind if you talk about maxillary CA? Okay, so the different thing that should come into mind is the presentation is similar to that of your maxillary sinusitis. There will be opacities over here also, but whether that's an opacity because of an endoconal polyp or a sinonasal polyp, or whether that is a maxillary carcinoma, you have to rule out. Okay, and for ruling that out, CT scan becomes the best investigation. See, risk factor: hardwood dust. Hardwood dust is for adenocarcinoma. Softwood dust is for squamous cell carcinoma. Remember S for S. Okay, softwood for squamous cell carcinoma, hard dust for adenocarcinoma. And remember, those who work in factories making boot, BOOT, wood, they are more commonly affected with this one. Okay, so those who work in the boot, shoe, textile workers, and silicon, and this one, and remember this HPV, very very important. Okay, human papilloma virus, HPV, mustard gas exposure, human papilloma virus, boot, shoe, and textile workers, very very important. Okay, next let's come to the maxillary sinus malignancy. Okay, so you have your maxillary sinus over here. What do you have here? Nasal cavity. What do you have here? Orbit. What do you have here? Pterygoid plate. What do you have here? Your cheek area. What do you have here? Brain, right? So medial extension. Now, okay, so early clinical presentation: nasal stuffness, bloodstained nasal discharge, facial paresthesia, epiphora. Okay, epiphora, discharge from the eye. So eye, epistaxis, cheek swelling. So you can see this diagram. Yes, I was talking about this diagram. See here, medial extension to the nasal cavity. Okay, now there is a slight, anatomically anterior spread is towards here. This is taken as an anterior area. Okay, so this area, this is your medial. Please make this diagram with me. Okay, and this is taken as your anterior. So if this is taken as your anterior as a cheek area, okay, what is the inferior? Anterior and superior will be your orbit. Okay, superior will be your orbit. Inferior is your anterior is your this one. So what will be your posterior? Posterior will be your over here. This is your pterygoid plate. So let's check. Anterior is your towards the cheek, okay, and superior is towards your eyes, okay, and posterior is towards your pterygoid, okay, and then you have intracranial, and there is also one inferior spread, inferior. So over here, inferior is towards your, this is anterior, pterygoid is posterior, okay, posterior, anterior, posterior, superior, and inferior. Inferior must be over here, right? So inferior towards here, inferior. Now you will understand this very easily, okay? See here. If it goes medially, it is involving the nasal cavity. That will be nasal discharge will be there, nasal stuffiness will be there, congestion will be there, mass in the nose will be there. Okay. If it goes superiorly, in the eyes, there'll be a proptosis, there'll be epiphora, there'll be rectus palsy, okay, muscular palsy, diplopia. If it goes anteriorly towards the cheek, there'll be cheek swelling, there'll be facial paresthesia, okay. If it goes inferiorly towards your teeth, so here is your anterior portion, okay, here is your posterior portion. So posterior portion, P for posterior, P for pterygoid plate, okay, pterygoid plate. So there will be trismus, inability to move the jaw, right? And here, if it goes towards the teeth area, so at the teeth area, it is your inferior, superior is your eyes, right? So if it goes to the teeth area, so ill-fitting of dentures, teeth swelling, hard palate swelling. Similarly, there will be teeth loosening, okay. These are the different features that you see here. So this is your intracranial extension, this is your superior, this is your inferior, okay. This is your anterior, this is the intracranial, and towards the posterior side also there will be, okay, posterior side. And this is your nasal, okay, towards the nostril. Now medial spread towards the nasal cavity, unilateral nasal obstruction, unilateral purulent nasal discharge, epistaxis, unilateral fibril nasal mass. Anterior spread towards the cheek swelling, invasion to the facial skin. Inferior spread, that is inferiorly towards the teeth and the poor fitting of dentures, dental pain, right? Superior towards the eye, there will be proptosis, there will be diplopia, there will be ocular pain. And posterior, there will be pterygoid muscle involvement leading to trismus, right? Intracranial extension can be done, and then neck node metastasis in late stages, there will be. And hematogenous spread can also be there, and it can spread to the lungs and bones, okay. It can spread to the lungs and bones. Remember, metastasis to the bone is more commonly seen with which of the tumor? Thyroid tumors. It's seen with thyroid tumors, and it's seen with lung tumors, okay. So lung tumors, thyroid tumors, okay, they are most first one is actually lung in the case of males, breast in the case of females, and other tumor are thyroid, prostate. These also tend to match to the brain, okay, match to the, sorry, not brain, okay, bones, match to the bones. So this was an extra information from your orthopedics. So intracranial spread can also be there, okay. See this cheek swelling. Cheek swelling means inferior spread, right? Alveolar. Cheek swelling was anterior, no. Cheek swelling was anterior. Yes, I often tend to forget, you don't, no forgetting, okay. Alveolar means towards the inferior spread, right? Nasal mass, that is a medial spread, very easy. Now diagnosis, how would you diagnose this case? Diagnostic nasal endoscopy can be done, and PNS can, X-ray PNS can, but the best is CT scan because the bony involvement. Because of the bony involvement, the best investigation of choice will be CT scan. You can also go for a biopsy. Now, X-ray of this paranasal sinuses is shown here with the opacifications at the maxillary area, opacified area. But this is not a diagnostic clue, okay. Of course, there will be mass at the palatine. Of course, there's diplopia, proptosis, and mass over here. Then there'll, of course, the diagnosis will be almost clear clinically itself, right? But CT scan becomes the most important diagnosis. See how it's spreading towards the orbit, how it's spreading towards the, it's going to the cribriform plate, it's breaking the cribriform plate, and it's trying to extend towards the brain. Over here, the total mass, see, total mass is there. Now there is on-grains classification and Lederman's classification. So what is this on-grains classification? So from the angle of the mandible to the medial canthus, you just draw a line. Okay, from the angle of the mandible to the medial canthus, you just draw a line like this. So any tumor who is above this line, it has a bad prognosis. Okay, because it's involving the orbit, it's involving the cranial region. But any tumor which is below this mass, below this area, has a good prognosis. This is known as on-grains line. So any line that is passing an imaginary plane extending from the medial canthus of the eye to the angle of the mandible, suprastructure growth situated above this plane has a poorer prognosis. Infrastructure growth situated below this plane has a better prognosis. Okay, so these are actually the prognostic marker for sinonasal tumor. Lederman's classification means that one line is drawn from the base of the orbit, the other line will be drawn from above the alveoli, this floor of the maxillary sinus. Okay, below the floor of the maxillary sinus. So there is the floor of the maxillary, line drawn through the floor of the maxillary sinus, and line drawn through the floor of the orbit. Okay, so floor, both floor, right? So, and suprastructure, mesostructure, and infrastructure. Now you need to know this. Okay, this is slightly complicated, but the most importantly used is the on-grains classification. OHNGRENS. Okay, on-grains. on-grains. Lederman. See, two horizontal lines are drawn through the floors of the orbit and the maxillary sinus. Floors of the orbit and floors of the maxillary sinus. Very easy. Suprastructure, ethmoidal, sphenoidal, frontal, and olfactory area of the nose. Mesostructure, maxillary sinus, and the respiratory part of the nose. And then you have the alveolar process. Can you see? Respiratory part of the nose is maximally seen over here. And here you have the maxillary sinus. And infrastructure, you just have one alveolar process and one bone. Okay, alveolar process and a teeth. Okay, and here what you have the cribriform plate of the ethmoid. You have the cristagalli. This marked structure is actually the cristagalli. This pointing like mass, it's a cristagalli. This is your ethmoidal sinuses. This is your eye. Superiorly, what you'll have? You'll have an intracranial extension. So any tumor which is at the suprastructure has a bad prognosis, of course. Now let's come to the TNM staging. So TNM staging, very difficult to remember with this one, but still I'll try to make it much more easier. So T1 means, remember, T1 means it is involving your only mucosa, only nasal mucosa. Okay, so you understand this way, just listen to me carefully. T1 means it's involving only the nasal mucosa. T2 means, remember, if you just do this, make this 2 ulta, this will be like an S, right? So involvement of the soft tissues of nasopharynx, oropharynx, wherever there is. Okay, and 3 means 3-letter word. So 3-letter word is P and S. So that is involvement of the paranasal sinus and the surrounding structure. And T4 means all the other extensions, major extensions like orbit extension, intracranial extension. Okay, these all are actually T4, taken under T4. Okay, T1 means tumor confined to the internal mucosa. There's bone destruction. T2 in bone destruction of the hard palate and middle meatus. Okay, sorry, not S. Okay, so I got confused over here. That classification, that TNM classification which I told you latest, that is the classification for your nasopharyngeal cancer. Okay, I'm very sorry, I just confused with this one. So T1 means here it's confined to the antral mucosa. Okay, there also it was the same thing, nasopharynx. T2 means there's a bone destruction. T2 means there's a bone destruction. Okay, there's a bone destruction. T2 means there's a bone destruction. T3 means involvement of the skin of the cheek, floor, medial wall of the orbit, ethmoidal sinus, posterior antral wall, pterygoid plates, infratemporal fossa. And T4 means involvement of the orbital content, cribriform plate, frontal and sphenoid sinus, skull base, and nasopharynx. Moreover, this you can actually remember with the Lederman's classification also. Okay, Lederman's classification. So how with the Lederman's classification? See, T1 says it's confined to the antral mucosa. It's okay, just antral mucosa, finish. Okay. T2 means there's a bony involvement. Now, bony involvement of the hard palate and the middle meatus. So this hard palate and the middle meatus is this one, no? The meso area, the meso structure, right? So hard palate as well as the hard palate as well as your middle meatus, if it's involved, it is T2. It's just going here and it's just going down. Okay, but now it's coming to the T3, involvement of the skin of the cheek, floor of the medial wall of the orbit, ethmoidal sinus, posterior antral wall, pterygoid plate, infratemporal fossa. In this area, skin of the cheek, floor of the medial wall of the orbit, ethmoidal sinus, posterior antral wall, pterygoid plates, infratemporal, this around this area, all around this area, okay. And if it's involving more than over here, superior part, orbit, your intracranial part, skull base, spinal sinus, this is all towards a T4, okay. The ethmoidal sinus, base of the floor, okay, base, orbital floor, pterygoid plate, okay, these all are T3. Now treatment, how are you going to treat this condition? You are going for surgery and radiotherapy. You are going for surgery and radiotherapy. T3 surgery and radiotherapy, T4 surgical, radical therapy and chemotherapy, right? And there is the guidelines of neoadjuvant therapy as well as the chemotherapy. Okay, neoadjuvant therapy means chemotherapy that is given before the surgery to regress the size of the tumor. Okay? To regress the size of the tumor. Now, next thing that you need to remember here is different approaches. Like one is total maxillectomy by Weber's-Ferguson incision from here. Weber's-Ferguson's incision. Okay. Or it can also involve lateral rhinotomy incision. Lateral rhinotomy incision, Weber's-Ferguson incision. Okay. And sometimes it's an important with orbital exenteration. Orbital exenteration means you are removing all the contents of the orbit, right? Orbital exenteration. Orbital exenteration. And sometimes it's important to remove the areas of your palate. Okay, areas of your palate. Okay. So total maxillectomy, Weber's-Ferguson incision, total maxillectomy, palatal defects, and then you are keeping some prosthesis. Orbital extension indication, involvement of the orbital apex, involvement of the extraocular muscles, involvement of the bulbar conjunctiva or sclera, lead involvement beyond a reasonable hope for reconstruction, non-resectable full thickness invasion into the periorbital into the retroorbital fat. Okay, so we have to also go for orbital extension. Just remember, if you just remember this word orbital extension, it will be more than enough. Okay, so we are keeping a prosthesis. See, prosthesis kept. Midfacial Weber-Ferguson's incision, lateral rhinotomy incision, craniofacial resection, craniofacial resection, craniofacial resection, craniofacial resection, midfacial degloving, lateral Ferguson, Weber's-Ferguson, craniofacial, okay. Use of prosthesis, orbital extension. These all are actually the methods by which we can go for total maxillectomies. Now let's revise all the things that we have studied in the case of sinonasal tumor. Sinonasal tumor, first thing we studied was osteomas, was an incidental finding in your frontal sinus. Second thing we studied was ossifying fibroma. Ossifying fibroma was actually a mass that was seen in your the mass that was seen in your maxillary sinus, and this ossifying fibroma used to this ossifying fibroma is actually changing from the medullary pattern to the fibrous pattern, and that leads to sinusitis-like feature. So you have to rule out whether that's a sinusitis or whether that's a tumor. Okay, and whenever we talk about the methods by which we remove the ossifying fibroma, this was by complete extension, complete eradication of the tumor. Okay, and whenever we talk about osteomas was released by bicornal flap repair, bicornal flap incision. Okay, and next thing that we need to remember is we studied about inverted papilloma. Inverted papilloma, we give a lateral Ferguson incision, or we go for a Weber-Ferguson incision, lateral rhinotomy or Weber-Ferguson. Okay. And whenever we talk about inverted papilloma, why is not an inverted? Very important question. Second thing is inverted papilloma. Whenever we talk about inverted papilloma, pale friable mass arising from the middle meatus. Okay, these are important. And maxillary carcinoma, soft dust, hard dust. Soft dust, squamous cell carcinoma, hard dust, adenocarcinoma. And different features, we have already talked about this one. So this completes our lecture on maxillary sinus.